afternoon once again. After that elaborate lecture on how a meniscus is formed out of what fibers and the functionality of meniscus, now let's move on to see how this meniscus structure can get disturbed. Meniscus can tear, and this meniscus can tear in different ways and in different fashion. It could be a different pattern of tears based on the orientation of the tears with relation to the orientation of the fibers which align the meniscus. Now, if something is running along the circumference or longitudinal, this is called as the longitudinal tear along the road of your fibers, and these are parallel to the load-bearing fibers, and they have a small effect on meniscal functions. So these are by and large not so notorious tears, and many of them can be left alone. On the contrary, something which cuts through parallelly or perpendicularly the orientation of your meniscal fibers. These are called as the radial tears, and they cross the load-bearing fibers, and these they have a larger effect on the functionality of the meniscus. And these tears left alone can be much more hazardous to the knee. A horizontal cleavage tear, this is like a sandwich tear, or what we call as a horizontal cleavage, which cleaves the meniscus through and through in a horizontal direction, hence opening up the meniscus. And most of these tears are occult tears. They may be associated with some kind of discoid meniscus, or as we saw in the morning, both the cases did have occult horizontal cleavage tear types. And these tears needs to be recognized, and either they could be just debrided, or they might as well be repaired. Flap tears, very commonly seen. These are mostly degenerative tears. The flap tear could be either in the substance or in the periphery. Most commonly, what we see is the flap tears, which we see in the white zone, which is just a small flake of meniscal tissue lying and dangling there. And most of them would just require a debridement until unless these flap tears extend posteriorly or extend towards the periphery, forming a kind of a radial tear. Bucket handle tear, typically take a handle of the bucket and put it across. So this is what happens. The bucketing of the meniscus, they usually happen either in the mid substance or in the capsulomeniscal junction, and the entire substance of the meniscus falls into the intercondylar notch, hence causing locking, clicking, and so on and so forth. And this could be either one of the horns, either a posterior horn tear, which can be bucketed, or the entire of a meniscus, which can bucket into the intercondylar notch. Complex tears. This is kind of a combination of various tears. Here what you see is a root tear, which is complexed with the radial and a longitudinal tear, and of course the horizontal tear. These kind of tears are usually chronic tears. It doesn't happen in acute settings, and they have to be catered, and they have to be catered well. Capsulomeniscal junction tears these are the tears which are missed very commonly, especially in acute settings. As you see here, this is the peripheral most tear, where there's a tear of the meniscus, or a detachment of the meniscus from the capsulomeniscal junction. And if the tear is quite big, it is extending into both the surfaces, superiorly and inferiorly, it's always a good idea to go and repair it. An extension of your capsulomeniscal junction tears are nothing else but a ramp lesions, which is most commonly seen in ACL tears. About 7 to 14% of your ACL tears do have, by literature, ramp lesions, and they are nothing else but capsulomeniscal detachment or the meniscotibial ligament disruption in the posteromedial aspect of the knee joint. What you need to do, just introduce the telescope between your PCL and your medial femoral condyle. Go into the posteromedial compartment, visualize this, and in case if it's a fresh injury, it would look something like that, or else if it's a chronic injury, it could get buried within a few fibrous tissue. Hence, it's called as a hidden lesion. Now, decision making of a meniscal tear. Let me just show you a couple of cases. This is one of my earlier cases in my younger days of career. Very enthusiastic, saw this tear, got excited, took a single all-inside meniscal suturing device and went ahead and repaired this tear. This is the chronic radial tear, a complete radial tear. Here, the biology was weak, young active individual, and of course, budget constrained, where I went in and just repaired with one meniscal stitch. I felt good, came out very happy, thought that I did a good job. Post-operative rehab, the patient was not very keen on that. And this is what he comes to me after 1.5 years with the persistent pain, and an MRI would show radial tear which is not healed or given way. Now, the reasons for failure: why do meniscal tears or meniscal repairs fail? a wrong selection of patient or a tear pattern, inadequate or improper repair, or other factors which could be either a patient factor or the biology in the body. Current criteria for meniscus repair, let me quickly rush into this. Vertical, complete vertical or a longitudinal tear more than 1 centimeter in length, tear that demonstrates instability while probing, tears within 3 to 4 millimeters of meniscocapsular junction, that is more of a peripheral tear, and associated lesions like an associated ligamentous lesions and an active patient without any osteoarthritis in the knee joint. What is the incidence of failure rates? About 10% of lateral meniscus repairs fail, whereas the medial meniscus repair fail in about 30% of the cases. Factors which affect healing of the meniscus repairs, a combined ACL reconstruction with the meniscus repair does have shown to be having a better effect, maybe because the biology is enhanced with all those bone marrow substances inside the osteogenic substances inside the knee joint after the reaming of the ACL tunnels. Isolated tears have about 57% of healing rates. Hence, a combined repair is usually better. Peripheral tears heal better. That's not something which we do not know about, especially the rim width. Now, width of a tear from the margin of your lateral margin of your meniscus. In the healed group, mostly it's about 2.2 millimeters. That means the tears which are more towards the periphery heal better than in the unhealed group, which are more towards the central. Age of the patient, it's astonishing to see the data. You usually see that the increased healing rate with the increasing age. Maybe this may be attributed to the low level of activity or probably the post-operative immobilization or weight bearing, which the elderly patients are more compliant than the athletic population. Non-athletic patients have more risk of recurrence though. Tear length, 80% of the tear healing in about 3 centimeters of tear. And if the tear length is more than 3 to 4 centimeters, one would have about 67% of failure rates. Lateral meniscus heals better than the medial meniscus, and the best timing for your meniscus surgery is within 6 weeks of your meniscus tear. Look at this case scenario: a housewife, obese, low velocity injury, comes to me about 6 months later, repeated locking and neglected. The best thing to do over here is to just do a partial meniscectomy and probably retain the peripheral 1/3 of your meniscus, which will be functionally sufficient for the patient. On the contrary, a football player, an ACL and meniscus repair done elsewhere with a single or two suture devices, comes back again after about a year. We here need to remember that most of the failure rates of a meniscus repair are after 18 months to 2 years. So nobody comes to you with a meniscus repair failure in the first half of his repair. Now, this tear is easily reducible. There's a good biology in the periphery. This is the old stitches over here. Young active individual who would want to return back to his sports and the cartilage is good. These tears definitely need to be redone or re-repaired, and there's no role in today's date to knock off this kind of medial meniscus, especially in young active individuals with good healing potential and a good biology. How do I repair it? The repair techniques have been shown by Dr. Nagaraj. I'm not going to show that again. One more peculiar kind of meniscus tear is a discoid meniscus tears. Usually these are concealed tears when patients repeatedly come to us with lateral joint line pain and tenderness. Discoid meniscus tears, I was telling you, these are mostly concealed tears within the discoid meniscus. We need to probe into that, look into it, do a debulking of the discoid meniscus, and if we feel that any form of intervention in terms of repair is required, one could go ahead and repair them. Meniscal tear with cyst, this is what we are talking about in the morning. Usually, as we all saw in the morning, these are concealed tears. One needs to open up the meniscal cyst either from inside out or from outside in. One could open up the cyst from outside in using a wide bore needle or a broad needle cannula, and you would see a gush of fluid which would come from outside in, and once the cyst wall is broken, one would go ahead, use a narrow shaver or a thin low profile shaver and decorticate the cyst wall, and if required, one could go ahead and repair this kind of meniscal cysts. Meniscal root tears, I'm not going to elaborate on this because Dr. Vivek Pandey is going to speak on this. Most commonly type 2 tears and type 5 tears, which are root avulsions, are which we routinely encounter. Ideal patients for root repair would be less than 65 years, active individuals with low grade or no osteoarthritis, and willingness to non-weight bear for 6 weeks. Definitely, this is not a candidate for a root repair with such kind of grade 3 or grade 4 of osteoarthritis on bicondylar level. Even though such patients do have root tears, I think an ideal option would just to be do a high tibial osteotomy. Considering the role of meniscus in maintaining knee function and preventing arthritis, meniscus repair surgery would be considered whenever possible, especially younger patients with peripheral tears and good tissue quality. Complex tears with root, body, and pan meniscus tears in younger individuals, it may be difficult, but one needs to go ahead and repair them for the benefit of the knee and the cartilage. Transection tears with retraction. This is sometimes what we see. We may be in for surprises, but even in such situations where the individual is young, especially the lateral meniscus, with the good healing biology and peripheral tears or transected tears, one would make an attempt to save whatever remnant tissue is possible, either with various suturing device techniques. Treatment of meniscus repairs, it should be a customized approach depending on the tear pattern, location of the tear, vascularity, and of course the patient factors. Thank you.